That's so sweet. Thank you for that kind introduction, Sina. It's been a pleasure so far and excited for more. So, this is a kind of important topic for me, and anyone in the audience who's a clinician and actively treats patients with PRP, MSC type treatments, bone marrow fat. I'm going to focus primarily on PRP for this one, but I'm going to go ahead and share my screen and hopefully this will work. Okay, so we're going to be talking about, some of the silent variables and how to improve your outcomes, specific to like apart from the platelet. And I kind of wanted to talk a little bit about cells and wound healing and matrix formation, because I think it all starts from the basic science. And if we have a reasonably good handle on that, we'll understand why we have to hold the medicines and supplements that I'll talk about. So these are my disclosures. So healing is actually quite a complex orchestra, symphony of different cells and growth factors and cytokines that come together to help us heal. So we're going to go over a musculoskeletal injury and the body's natural healing response. We're going to talk about a multitude of factors beyond the platelet that affect tissue regeneration. We're going to talk about the interconnectedness of inflammation, cell recruitment, matrix deposition, and remodeling. And then we're going to talk about the effects of NSAIDs on orthobiologics, as well as some common supplements on orthobiologics. So mononuclear leukocytes are really the orchestrators of early healing. Monocytes, macrophages, lymphocytes, and they help with phagocytosis of debris and pathogens, help with secretion of cytokines, growth factors that modulate inflammation, help with recruitment of other cells, including fibroblasts. And they help transition the cell environment from a pro-inflammatory to an anti-inflammatory phenotype, which is crucial for healing progression. And it functions along with MSCs with a paracrine effect. So you get trophic effects, immunomodulatory effects, antimicrobial effects that restore the natural environment, resulting in a functional remodeling, contraction, proliferation and migration, hemostasis, pro-inflammation, and angiogenesis. So collagen is super important, right? So the fibroblasts are the collagen architects, and effectively, fibroblasts are the primary cells. Growth factors and cytokines recruit them to the injury site, and that results in a pro-collagen synthesis and its extracellular processing into collagen fibrils. So transcription and translation from the ribosome results in hydrolation and glycosylation of proline and lysine residues. That gives you a triple helix formation, secretion of procollagen in the extracellular space, cleavage of propeptides by enzymes, self-assembly of collagen molecules into fibrils, and then collagen cross-linking. And this is, I think, the most important step, the collagen cross-linking, that can result in good healing, slow healing, excellent healing, biomechanical strength and resilience. And this is where we can really start affecting our outcomes. So the collagen maturation and cross-linking process is super important. And a main enzyme is lysyl oxidase, or LOX. And it's super important to this tensile strength and stability of healing tissues. And we know that collagen maturation can take months to even years. Jane Fitzpatrick just presented at the Biologic Association on gluteal tendon improvement on MRI even 7 years later. So loss can be affected indirectly and directly by NSAIDs, supplements, peptides, and nutrition, and that may affect healing. So we'll talk about nonsteroidals. So obviously we have non-selective nonsteroidals like ibuprofen, naproxen, diclofenac, indomethacin, that kind of thing. And there's some studies that show that this actually may delay wound healing, particularly in the early phases, by inhibiting inflammation, which is crucial for cellular recruitment like MSCs, and as well as macrophages and matrix deposition. And this results in reducing fibroblast proliferation and collagen deposition. And so their short-term use is probably okay, maybe less concerning, but the problem is we don't really know what the threshold is, both for dose as well as duration of use. Tendon healing, we know that it inhibits tendon cell proliferation and migration, and this may potentially affect the early stages of repair. And some studies show increased collagen synthesis, but the biomechanical strength is decreased. So joint healing, we know the long-term use of nonsteroidals results in collagen breakdown, including articular cartilage, by inhibiting chondrocyte proliferation and matrix synthesis, and this may inhibit bone healing in the joint. How about the partially selective nonsteroidals? So these would be like celecoxib or Celebrex, even meloxicam is considered this. They don't typically significantly affect platelet aggregation or adhesion or degranulation in studies, but they do still affect the prostaglandin axes of inflammation. And this may impair bone and soft tissue healing, potentially even more so than non-selective nonsteroidals in certain contexts, like bone healing. So there's really no consensus yet on tendon and joint healing, but I would just exercise caution when using nonsteroidals, especially the COX-2s. So general considerations is I have people avoiding all nonsteroidals, COX-1 and COX-2s, as well as aspirin. I do actually hold Tylenol now as well, because at high doses that can affect platelet aggregation as well. And I avoided a week before and for the first 3 weeks after which I do let some people in a limited fashion and on a case-by-case basis use the lowest minimally effective dose, particularly if it helps to allow earlier rehabilitation. I do tend to favor meloxicam and Celebrex over the COX-1s, based on what I just talked about. And I would just say, as a summary, there's direct and indirect variables affecting immunomodulation, tissue regeneration, and biomechanical properties. We know that nonsteroidals can provide pain relief, but their potential negative effects on tissue regeneration should be carefully considered, especially for long-term use. So how about nutrition, right? We are what we eat. We feel what we eat. I've posted a lot about this on LinkedIn. Microbiome matters, right? And we know that nutrition affects LOX, that ultra important enzyme that affects collagen formation and cross-linking. So I encourage copper-rich foods like shellfish, nuts, cashews, seeds, and whole grains. I talk about vitamin C sources, preferably in the diets with citrus, berries, bell peppers, and leafy greens. But if they don't have a great diet, I do tend to say, supplement vitamin C. Bone broths have a lot of collagen precursors and amino acids like glycine and proline, which contribute to collagen formation. Egg whites are rich in proline as well. And then garlic has some sulfur compounds that support collagen production and affects LOX directly. Now, if someone has a terrible diet and you just know they're not going to be around to cook and be healthy, and there's no one around to help them, I actually get people on Prolon. If you look that one up, that's actually meal prep, and it's very similar to this. It gives you kind of all of these, substances and, fairly low carb. And what's interesting is people lose a lot of weight actually. And so I started a week before and recommend 3 weeks after. How about supplements? Well, there's really not a lot of studies that I could find on orthobiologics and supplements themselves. There's a lot on longevity, on inflammation, and so I'm sort of interpolating a little bit here. I will say that individual responses may vary by supplement. There's a huge variety of quality of the same supplement on the market because of poor regulation. Dosing and timing is certainly not established, and so we just have to proceed with caution. Doesn't mean it won't help, but a lot more study needs to happen. So the supplements that I talk routinely to my patients about are omega-3 fatty acids, which reduce inflammations. And I start at 5 days post and I hold it 3 days before. So it's primarily for bruising risk. Similar with curcumin, turmeric stimulates collagen synthesis and protects collagen fibers from oxidative stress. And I start that about 5 days post because, again, I don't want to blunt that acute inflammatory stage. Vitamin C, cofactor for enzymes to stabilize collagen. I start it a week before and continue for a long time on this one, 4 months after. Zinc, cofactor for collagen synthesis and protects against degradation. So again, I start that a week before and 4 months after. Vitamin D3, lots of people are low in vitamin D, and I always ask this in my initial intake consult. And a lot of people are like, oh yeah, I'm in the low 20s. That's not enough. Even 30 is not enough. And so when you look at some of these athletic articles, particularly for stress fractures and tendinopathy, we kind of want them above 50. So I have a very low threshold for putting on people on 5,000 IUs per day. knowing what the baseline vitamin D is, and then recheck in 3 months and make sure they're not toxic. Collagen peptides like BPC 157 and TB 500. You'll hear a lot more of that if you're not already. Be careful with your states. Some states don't allow the physician to administer it. There is an oral form of these two peptides, which can be quite helpful. L-arginine, which is kind of an ergogenic for exercise, helps certain microcirculation. BPC we talked about. Resveratrol, nicotinamide riboside, which is an NAD precursor. Quercetin, very interesting substance, anti-aging, sirtuin 1 influencer, betaine, and resveratrol. And then urolithin, which is basically helps, or might appear as a brand, helps with mitophagy. And so I'm starting to talk a lot more about how do we energize the healing engine of the body. You put your platelets in, it takes a tremendous amount of energy to actually then follow through with a good healing cascade. And so I try and energize with various things such as these supplements, photobiomodulation, shockwave, that kind of thing. So for me, immediately after my procedures, I am treating with the MLS laser and EMTT. I have people work with red light therapy at home, and even a hyperbaric oxygen. Again, we just have to energize the system, and that can help with healing. But remember that we have to be clinicians, and not all of these treatment are needed for everyone. So we have to be clinically precise. So that's about it. Thank you so much.
That's great. Thank you so much, Dr. Paul. Very, very informative and very dense. So also, I'm going to talk about some of the stuff you already talked, but my consideration is mostly for the diet. Already our patients are already on those diet, and before drawing the blood and preparation, the PRP, and how these supplements or diet can affect our PRP outcome and PRP function. So we can discuss more after my presentation. Maybe at some point we don't have disagreement on that, but maybe we need to make it more clear for our audience, specifically regarding some vitamins like vitamin E and vitamin C. I totally agree for regeneration. We need the vitamin C for collagen synthesis, but if we go for the vitamin C as our daily vitamin supplement for a long time before drawing the pure blood and PRP, it can affect somehow the platelet aggregation and activation. So we need to talk, and we need to go for more details. And so, yeah, we are going to talk about that. So let me check the... okay, we have our questions through the chat. Please send a question through the chat. Dr. Paul, do you have access to the chat panel?
I think I do.
I think you should.
Yep, I agree with BIM, BPC 157. That's a really good point. If you're treating competitive athletes who are being drug tested, absolutely, we have to be careful with BPC. And I think TB 500 is being considered as well. Yeah, that's a good point.
So if you agree, our audience, we can start. I can start my presentation, and hopefully I could be done in 15 minutes, 20 minutes, and then we could have more discussion through the question and answer session.
Sounds good.
Okay.